Hi, everyone. Welcome. Today, we're going to be talking about health, and health is such an important topic. I think, if anything, these past few years, it's made us realize that health policy is so important, which is why we're so grateful to have Dr. Lefkowitz here today to discuss healthcare, specifically as it relates to income disparities, as well as successes and shortcomings of the healthcare policies that help determine healthcare access today. And with that, we're so glad you're here today, Dr. Lefkowitz. Thank you for joining us. And let's go
Thank
ahead and
you.
get started right into our first question. So, given your experience with your PhD in social ecology, what does social ecology entail, and why is it important to consider when working with policy?
I love the field of social ecology. It was a discovery later in my adult life, and once I discovered it, could not imagine why would one not use social ecology for analyzing healthcare, health service delivery. It's a framework for analyzing individuals in relation to their environment. It comes out of earlier movements where people were looking at people in relation to their neighborhoods or their cities. That was human ecology in the 1930s. Social ecology considers environment a little bit more broadly to encompass things like policy, institutional relationships, as well as interpersonal relationships. So it's really looking at the interplay of individuals with all of these different components of the environment. And so it's not looking at isolated variables. It's a really integrated approach. It's not looking at one directional influence. It's looking at bidirectional influence. So individuals impact, but also are impacted by their environments. It assumes that there's change over time. It assumes that the environment is multidimensional and that relations between humans and their environment occur at multiple scales. So this provides a really flexible as well as integrated framework for doing research that can have real world impacts on pressing social problems. And I think that's very compelling. So specifically in terms of policy, if we think about policy as part of the human environment, part of the human environment interactions, then we see policy as really part of this ecology, not as a standalone. And that's really important. It's also really important to understand diverse stakeholder perspectives in developing policy and where we can most effectively intervene. So social ecology draws from systems theory and looks at how one change in the system actually produces multiple changes. So you can't just tinker with one thing without changing the whole ecology. And therefore, changing how the system works is really what we're looking at to achieve better health outcomes.
Thank you so much, Dr. Lefkowitz. I think that was a really good foundation for the topic today. Going to this next question, I know you've done a lot of research on the inequities of the healthcare system here in the United States, and specifically on various factors like income disparities, access to healthcare in the first place, health information, and also, I guess, the flip to that, the amount of misinformation that exists in our society, and also like, legal services and the opportunities that people have to actually get the care that they need. With all that said, what would you say are the biggest benefits and also the biggest detriments current policy in the US creates for low-income people who might be struggling with their healthcare needs?
It's a great question. I think benefits, I would have to say the Affordable Care Act. I think it gets a lot of bad press, but in terms of people who are low income and low resourced, the Affordable Care Act creates access to insurance, which is one of the important components of access to care. It's necessary, but not sufficient. And it is almost universal. It does exclude people who are not legal immigrants, but it is otherwise inclusive of groups of people that have been excluded historically from insurance, either through their employment, which didn't offer insurance, or through income, not being able to afford it, and or through pre-existing conditions, which essentially precluded people from being able to access insurance afterwards. And I think in particular, the Medicaid expansion component of the Affordable Care Act has been a huge benefit for low-income individuals, increasing the access to people up to 138% of the federal poverty line in at present 41 states in the US, including the District of Columbia. In terms of detriments, I think we have to say our healthcare system is really broken. It's very fragmented. And what that means, I mean, a lot of people say that, but what that means is that it takes a lot of work to get access to care, and that work is disproportionate if you have low income. And why is that so? Well, everybody has to do that work, but if you have fewer resources, less flexibility in your job, less ability to take time off, you can't afford to take time off because you have no sick leave from your job, this is actually going to really impair your ability to get health care. So I think that what has been called admin by other scholars really increases the burden of access for those who are able to least afford it. I think also the state-by-state policies, while that can sometimes be a benefit, can really disadvantage people in certain states. Medicaid expansion being one example of that, where Medicaid is a federal-state partnership, but has very loose guidelines that are interpreted by every state. Every state operates its own Medicaid program, and as a result, the benefit level as well as the eligibility threshold vary very widely from state to state. And I think that it can be a forum for experimentation, but it ends up being a real disadvantage and creating inequities for people across the US. So I would say those are some of the more important exclusions and detriments.
Thank you so much. Yeah, that's very important. I think when you talk about access to care, it's important to make sure that we can include as many people, but we also have to understand that once we do include people, that doesn't mean we're going to be 100% efficient. It's going to be working 100%. So kind of going off of that, relating back to your background in social ecology, to what extent does the stigma behind people in low-income backgrounds specifically affect their access to medical treatments, but also to diagnoses?
That's a really good question, and my work is not focused on stigma per se, but I think it's important to consider to what extent people who have low income are stigmatized in the healthcare system. I would say that stigma is a more serious barrier for people with disabilities and or people with serious mental illness, but there's considerable overlap because people with disabilities or serious mental illness are disproportionately low income. So when people who have low incomes encounter the healthcare system, how is it that they are identified as low income? I think it's primarily through the type of insurance. So then we have to look at what happens with people with Medicaid. Now, in my research, I have heard a number of people speak quite openly and with a lot of frustration about having Medicaid, Medi-Cal in California, doctors not wanting to treat them, not providing the same level of care, not taking the same amount of time. And this is certainly possibly related to stigma, but I think that we need to consider some other possibilities. And from a social ecological perspective, we can see that stigma is really at the interpersonal level. It's about what happens between a provider and a patient. It's also a way of talking about a characteristic of the person seeking healthcare that becomes stigmatized in that interpersonal relationship. And certainly that's not unimportant. It suggests that access is partly a problem of bias. However, we could also see that workplace policies can seriously affect access, as I just mentioned. So it's not simply the bias, but it's that people who have Medicaid insurance are more likely to have jobs that don't provide time off or flexibility to take time off. We could also look at provider practices. So if your job does not allow you flexibility to take time off and your doctor's hours of appointments coincide exactly with your work hours, that's a problem. It's a real barrier. And another example, CMS, the Centers for Medicare and Medicaid, set the threshold for reimbursement for Medicaid services. And therefore, if the doctors perceive that Medicare and Medicaid reimburse at too low a level, that will be a real disincentive for them, especially since there's a huge paperwork burden required by Medicaid. So all of these things, which I would say are part of expanding our understanding of structural barriers, not just looking at individual level barriers, can come into play for people who are low income.
It's really interesting to hear about the different layers there exist in this issue in terms of low income families and individuals getting the care they need. You know, you briefly mentioned how stigma is very correlated and it plays a big role in terms of interpersonal relationships, and how, you know, some people might think that, you know, a basic policy change might be a solution, but then when you have, you know, human nature getting in the way of things, it makes it so much more difficult and challenging to solve these kinds of issues from a policy perspective. So kind of leading from the conversation we've been having, what are the most important changes that you think need to be made in order to set us up as a society to be in a better position to advocate for and also ultimately provide people who might be from lower income backgrounds who don't have the resources or access to healthcare? What kind of changes are you looking at from the research perspective?
Well, I think universal insurance would make a tremendous difference for most of us, but especially for people who are currently without adequate access to healthcare. And now there's proposals that have been circulating in the last few years for Medicare for All, which is one version of a universal insurance policy. And it seems to raise all sorts of fears in this country. I actually think what people should be really scared about is getting seriously ill within our current healthcare system. People tend to think that they will lose the freedom of choice about their insurance, about their healthcare. I actually think it's a real mistake to think that we could actually make informed choices in advance about the best health insurance for our own needs, which is not to say that we can't think about these issues, but simply that no one can ever really anticipate what their healthcare needs might be in the future. You can only understand when you're in a situation and your insurance doesn't cover what you need, a drug, a procedure, in order to recover from your illness. So there's a lot of concern also about the government making healthcare decisions. I hear a lot less discussion about insurance companies making healthcare decisions. That's essentially the system that we have now, where you need prior authorization from many healthcare plans for many types of procedures. And it's essentially insurance adjusters who are making those healthcare decisions. Sometimes they're life and death decisions. We've been seeing a lot of discussions in the news recently about these kinds of things. For example, United Healthcare just announced that they will no longer be covering screening colonoscopies and diagnostic colonoscopies, only those that are preventive as part of preventive care, which means with the healthiest of individuals. That's a very recent announcement. Will have huge consequences for people with likely delay and later stage diagnosis of cancer. While I think universal coverage would certainly benefit individuals, it would also benefit us as a society. The US spends the most per capita of any country in the world on healthcare. We certainly do not have the best health outcomes of any country in the world. So according to recent estimates, the US spends about twice as much per person for healthcare every year compared to other high-income countries like France, Sweden, Canada, the UK, Australia, Japan. So we have to consider what else we could be getting for that money that we're spending on healthcare. And I think that universal healthcare provides some real alternatives that we should consider.
Yeah, I think that's a very good point that you bring up, that the US, as we're spending significantly more money than other countries, we're not getting anywhere near what they're getting in terms of health outcomes. And so there's definitely a disparity there. So with that being said, what would you say are the most impactful policies today in the US that determine healthcare access as it is?
Great. This is a question I really enjoy thinking about because there are some things that are both obvious and less obvious in terms of what's currently available and working. Again, the Affordable Care Act, although the final version, when it was passed, had some unfortunate gaps that could be significantly improved, I think that it's underappreciated in this country for what it did accomplish. So I'll just mention a couple of ways that it enables healthcare access in addition to its almost universal inclusion. First, decouples health insurance from employment. Although the majority of Americans still obtain health insurance through their employers, this creates huge inequities. One employer is not equal to another employer. Big employers are able to offer bigger benefit packages. So there's huge disparities in terms of what the employer is offering the employee, as well as many workers, including most essential workers, who are working in low-wage jobs and have no benefits whatsoever. So it's really important to have an option for health insurance for people who cannot obtain insurance through their employment. Second, and this is also really important, the ACA removes the barrier to insurance of having a pre-existing health condition. Now, most of my research has been on cancer and seeing what happened to people historically when they got diagnosed with cancer before passage of the ACA is truly eye-opening. So many people, when they get cancer diagnoses, cannot work through their treatment or cannot work continuously through their treatment. And in the past, they would often get fired from their jobs. And then they found that with a pre-existing cancer diagnosis, they could not obtain health insurance at all, or the insurance was prohibitively expensive. So if we think today about how many in the people in the US have had COVID-19, that's most people in the US, that would be considered a pre-existing condition under pre-ACA circumstances. And we know that the ACA is constantly under attack. So if in the future, people who had had a COVID infection developed health problems that could be linked to that infection, then they would be excluded from health insurance. And this is currently the case for millions of Americans. Estimates range from 20 million upwards who currently are living with long COVID. Second policy that I think has really been tremendous, although it has many flaws as well, is the Family and Medical Leave Act of 1993, the FMLA. So this allows eligible employees to take up to 12 weeks of job-protected leave to take care of either themselves with a health condition or a family member. Now, it's unpaid leave. That's one of the problems because not everyone can afford to take unpaid leave. But it does provide important job protection during that leave, which means on returning to work, you can't be fired and you should be reinstated to the same job or a comparable job. There's some other things about what makes an employee eligible. It does exclude many people, many more people than are excluded from the Affordable Care Act. But nevertheless, the job protection afforded helps some individuals to retain employment that otherwise might lose their jobs, and therefore their employer-sponsored health insurance. Now, a third policy that we might not think of as something that enables access, but I certainly do, is state disability insurance. In California, we're really lucky to have a state disability insurance program, SDI, and it covers short-term partial income replacement up to 52 weeks, again, for eligible employees. But we are one of only 5 states in the US, including Puerto Rico, that offer a state disability insurance program. And this goes back already to 1946. So it's been a long time that we've had access to this. So it's a state level program, but the state does not pay for it. It's administered through California's Employment Development Department, but paid for through payroll deductions. So if you work for an employer that does payroll deductions, you are likely paying into the SDI program and can make use of it if you have a serious illness that requires taking time off work. So we can see how this SDI program works hand in hand with FMLA. If you qualify for both programs, then you can have some partial, it's up to about 60% of your full pay reimbursed while you're taking unpaid leave. Finally, I do want to mention an exciting recent development in Colorado. Colorado's Senate Bill 23-002 was just signed into law on May 10th of 2023. And this is the first time ever that Medicaid will reimburse for community health services. So community health services provide a huge amount of neighborhood level health education and patient navigation that helps especially low-income individuals in low-resourced communities navigate healthcare. And this is a first and hopefully a model that other states will emulate. And eventually we'd like to see federal level legislation that would pay for these services.
That's all really great to hear, and it's interesting to hear what the U.S. Has done. I know we've been talking a lot about what we should be doing, but it's still nice to hear that, and especially that on that last point about Colorado, I think that's really inspiring. I know it's only a state level policy, but it's still really great to hear that there's at least some action being done. Kind of going off of this question, what kinds of state level policies, and I know you mentioned a couple here, including the Colorado one, are there any other state level policies that have been passed, whether in California or beyond, that you think should be considered and potentially maybe implemented on the national level?
Well, that's a really big question. I think that, again, states are often incubators for experiments, and certainly CMS, Centers for Medicare and Medicaid, are using states as places to try out ideas and health systems within different states. So for example, now there's a lot of discussion about value-based care, and there's different models that have been tried out, and with there's always pitfalls. They work out some of the details. They have to try them out and implement them in real time, in real practices, in order to see what's working and what's not. I would say that one of the areas where states differ tremendously is around options for people who are undocumented. And in California, for example, if you get breast cancer or cervical cancer, there are two programs. It's a breast and cervical cancer treatment program. One of them is the federal version, and one of them is the state version. And in the state version, it is possible for people who do not have legal immigration status to be covered for their breast or cervical cancer treatment. The federal program has a longer time frame and is more expansive in the services that it covers, but at least the state level version allows people to get through cancer treatment. So, this is where we see real differences, and I think that issues like legal immigration status, which are so incredibly polarized, certainly also abortion now in the post-Dobbs decision landscape. These are issues where we're going to see radical differences between states.
Yeah, I think it's very important to highlight the issues of perceptions of healthcare and healthcare policy through not only policymakers and important officials, but also through the general public. And kind of branching off of that, to take a new perspective, you have a very inspiring career, and you are not only an accomplished researcher, but and an academic, but you're also an internationally recognized documentary, filmmaker, and visual artist. So you have created this vast body of work on how individuals confront traumatic and life-altering experiences. So given your experience with that, how important is it to bring light to these issues through the media? And what positive effects can they have towards helping inspire people to work to create lasting change?
I'm afraid I'm going to disappoint you in my answer on this. I spent about 15 years working as an independent documentary filmmaker, and some years after that working primarily as a visual artist. And I believed during that time that media was an incredibly powerful way of illuminating problems and building empathy and understanding across profound differences in people's lives. It was like opening a window and letting people in to see ways of living that they would otherwise not have access to. I have somewhat revised my opinion about the media, and that has a lot to do with the context in which people view media today. So I'll just say a few things that I've been thinking about. So when I started as a documentary filmmaker, people made films, not videos, not digital videos. Most often people viewed films collectively. They viewed them in classrooms, in movie theaters, in community centers. And as a communal experience, it generates discussion, it generates social connection, a sense of shared values and commitments. I think there's an excitement that's generated with people all watching something together and then walking out afterwards with conversations continuing. If people viewed films in the privacy of their homes, then it was on television, and then it was often a family activity. So nowadays, I think most people are consuming media in little chunks, short YouTube videos, and even shorter TikTok videos. And this works against the kind of nuance, the complexity, the in-depth investigation that was possible with longer format media. It also encourages a really short attention span and impatience, a demand for everything right now. And I think that works against really understanding how things are working today in society for healthcare and what needs to be changed, what's possible. I really think that complexity is missing from a lot of media. And third, if media invites viewers into the lives and problems of the people depicted, encouraging people to feel this could be me, or if this were me, how would I feel? That's a really powerful way of using media, and that's certainly what I thought I was doing. But media can also distance viewers from the lives and problems of people depicted and suggest to the viewer, oh, this would never be me. And in our politically polarized world, I fear that distance viewing is becoming more common than empathetic viewing, and that it takes more than simply a film or a television show to allow people to empathetically embrace someone else's perspective. And so in this sense, making media in today's world, I feel is less helpful for inspiring policy change. It's not to say that important, really powerful media productions are not still being made and watched on issues of social justice. But I think for me, the trajectory out of film and out of art making into research was a way of wanting to influence policy differently, using research as the foundation. So I don't know what your experience has been about viewing films and whether you've seen something recently that made you want to stand up and cheer or go out and do something. I'd be curious to hear.
Yeah, I think that's actually an interesting point that you bring up about how, which I had never considered. I know a lot of people talk about the attention span that has changed over the years, but about how this loss of the communal viewing doesn't spark the important conversations needed to create change. And that's something I'm gonna most definitely agree with you on, that now that media is more so viewed personally, we're not having these important conversations and hearing others people's ideas and opinions and beliefs so that we can better understand ours and those of the world around us, which I think is a great place to end because it really shows how healthcare and public policy both involve so many different players, and they're both very interdisciplinary. And to create policy that really makes sure that everyone is seen and everyone is heard, it takes a lot of work and so many different things coming together to make the perfect policy, which is why we have a lot of policies that are great in many ways, but it's just so difficult to create one ideal policy. So with that, thank you so much, Dr. Lefkowitz, for joining us today. It's been an honor to have you on the podcast.
Thank you so much. Pleasure talking to you.